One second. Let me. Yeah. So there's I think 4-5 of you over here. Are you all orthopedic? Are you all oncology trainees or orthopedic trainees?
Onco trainees, sir.
You're all onco trainees, and you're doing your DM or MCH or something of that sort.
Yes.
Or DN. Okay, and you've had sessions on sarcomas, adult and pediatric so far.
Not particularly pediatric, but yes, yes, sir. Ewing's was there.
Okay, so what I'm going to do is, because there are a few of you, feel free to interject and ask a question if you want to. I haven't covered the management, the entire management of these sarcomas. I have covered the chemotherapy part. So, as you know, the management would include surgery and radiation and timing and dose and everything else. But I haven't done it in its entirety. I have focused on the chemotherapy part. If you have any question, we can definitely discuss, or we can discuss in the end, whichever way. Okay. I don't know how many of you have seen the recent NCRP report which came out a month ago. Within that, there is a chapter on childhood cancer. And this table is taken from there. And these are the types of childhood cancer. But what I want you to focus on is malignant bone tumors and soft tissue sarcomas. So if you add it up on the right-hand column, between males and females, you're looking at 15 to 17%, or 12 to 15% of children with cancer have bone tumors and soft tissue tumors. So it forms, 1/6 of our patients have these cancers. So they are a significant amount of the work which we do. If you take this age group slightly older, so go to 0 to 19 years old, because we know that the peak incidence of several of these cancers is happening after the age of 15, the proportion goes up to nearly 15 to 20%, right? So somewhere between 1/6 to 1/5 of our total body of work would be children and young adolescents with bone tumors and soft tissue tumors. Now, if we look at the outcomes of these cancers, and over here I have just shown you the outcomes of osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma, and I'm showing you data from the US because we don't have this quality of data from the Indian context. And this is over the last 25, 30 years. What you see is, and I would like you to focus on the blue bars. So what you see is that osteosarcoma improved till the 80s, and it has been static since. Same with Ewing sarcoma, static for the last 15, 20 years. And same with rhabdomyosarcoma. So for many of these cancers, the progress which was made initially has plateaued, and more progress hasn't been made, or not to that extent, particularly in osteo. In Ewing's, there has been some recent progress, but in osteo and rhabdomyosarcoma, more progress has not been made. So when we give children chemotherapy, I would be covering these 4 broad categories: osteosarcoma, Ewing sarcoma, rhabdomyosarcoma, and umbrella of non-rhabdomyosarcoma, soft tissue sarcomas. Some of them you see in adults, and some of them are uniquely pediatric soft tissue sarcomas, which you will not encounter in adults. The purpose of chemotherapy generally is disease control, obviously, both the local disease as well as any micro or non-micro metastasis. It also is to reduce the size of the tumor so that the surgery which we do, it becomes non-mutilating, like a limb salvage surgery. It is also to assess the response to chemotherapy. So if you've got good necrosis, you can prognosticate better. And in certain situations, the necrosis is used to intensify treatment, but it is not always possible because we don't know what works. And finally, it can also be to palliate the symptoms. So starting with osteosarcoma, and like I said, please interrupt me if you have a question. I can only see the screen. I can't see any of you, so I would not know if there is something to be asked. So with regards to osteosarcoma, this graph I've shown you just before, that the outcome has plateaued. and the outcome in the 0 to 15 and 15 to 19 years is similar. Treatment requires a combination of systemic chemotherapy along with complete resection. In this case, radiation plays a very, very small role, if at all. There are small exceptions to the chemotherapy, which is a low-grade osteosarcoma in the parosteal region, or a low to intermediate grade osteosarcoma in the periosteal region. But except for this, osteosarcoma is high grade and needs chemotherapy. So some of the questions or the debates which I had in this area are whether, should we give chemotherapy or not give chemotherapy? Is it an obvious thing to do? Should we give chemotherapy before surgery or not give before surgery? What are the chemotherapy agents? And should we give 2 drugs, 3 drugs, or 4 drugs? And which chemotherapy regimen should we use? And what should we do when there is recurrence? Hang on, let me just see, why does this keep happening? Okay, you can still see the screen?
Yes, sir, it's visible, just not full screen.
Yeah, okay. I'm just trying to see if I can. Okay, so do you, how many people do we have now? 6 people, yeah. So does anybody want to kind of take, give their choices here, or give their opinion here about these questions which are there? Who would not like to give chemo? Okay, that's silence. So, okay, so I'm assuming, I'll take that as a yes, everybody. Who would not like to give neoadjuvant? Okay, so let's think. That's everybody wants to give neoadjuvant. How many of you use 2 drugs to treat osteosarcoma? Or are all of you using 3 drugs or 4 drugs?
3 drugs, sir.
Okay, so there's no one using 2 drugs. Okay, so let's go through this and see if we can generate more interaction. So the first thing is chemotherapy, yes or no? So historically, if you look, when people only amputated the leg, only 15 to 20% patients got cured, and the disease then came back. So which basically means is that in 15 to 20% of patients, if you choose correctly, you can get away without giving any chemotherapy. The problem is we don't know who those 15 to 20% are. And so we end up treating all of the patients. And that is historical data, which was how the whole practice started. So this made chemotherapy an integral part, which allowed us to push the outcomes from 20% to close to 70%. Now, when we give neoadjuvant chemotherapy, it seems quite logical, and actually that's the choice of treatment today. But the evidence is not there to support it. The trial which looked at doing immediate surgery versus giving neoadjuvant chemotherapy actually did not show a difference in the outcomes. And also, it actually showed no difference in the amputation rates. Approximately half the patients in both of the arms got amputation done. So, although it did not show a benefit in survival and it did not show a benefit in amputation, it has still become the standard of care for the reason because it is believed that it helps in salvaging of the limb, and also the information gained from the necrosis allows us to prognosticate. So in most cases, or from your point of view, in every case, you would go ahead and give neoadjuvant chemotherapy before operating the patient. So as I explained before, that the study was that it is still the preferred recommendation to give neoadjuvant chemotherapy, And the study did not show an advantage, but it was powered to show an advantage of 20% or more. So if that advantage exists, it's a small advantage for which the study was not powered. But because of the reasons mentioned over here, we continue to give neoadjuvant chemotherapy. What is perhaps not as well known is, and I think that's very important, is that the time of resumption of chemotherapy following surgery is important. So if you do the surgery and you commence the chemotherapy more than 2 weeks later versus you commence chemotherapy within the first 2 weeks, the outcomes are significantly different. And so if you're working in a center and providing care to these patients, please try not to delay chemotherapy for no unnecessary reason and try and initiate chemotherapy relatively quickly. Which chemotherapy agents to use? So you must have seen these agents in your practice. There are several drugs which have shown activity against osteosarcoma: platinum drugs, alkylating agents, doxorubicin, and high-dose methotrexate, of course. There was a systematic review which came out around 10 years ago. On the left-hand side, it compares 2 drugs versus 3 drugs. And I don't know if you can see my pointer over here, but the dotted line is outcome with 3 drugs, and the solid line is outcome with 2 drugs. And the lighter lines are the 95% confidence intervals. So there is believed to be a 10 to 12% difference in the outcomes, the EFS of patients who get 3 drugs versus 2 drugs. And same applies to the overall survival. Okay. However, when you do this for 3 drugs versus 4 drugs, over here the solid line and the dotted line overlap almost completely. And hence, this is not shown to be of added benefit. And so we personally over here use 3 drugs, and we would advocate a 3-drug protocol and not more than that. People have tried to add ifosfamide, and this is a study where they added ifosfamide. So if you see the graph, study arm A is, or drug A is without ifosfamide and drug B is with ifosfamide. They actually added a second randomization on something called muromyl tripeptide, or MTP. So if you ignore the MTP for now, what you will see is that A and B are actually not very different. But with the MTP, B becomes better, which is the top line, and without the MTP, B becomes worst, which is the bottom line. So the net result of this analysis was that adding ifosfamide to a 3-drug arm does not give added benefit. And if you go to the NCCN guidelines now, this is what is shown as the category 1 regimens of choice. So cisplatin and doxorubicin, which is the first, which is a 2-drug regimen, and MAP, or high-dose methotrexate, cisplatin, doxorubicin, which is a 3-drug regimen. And because of the systematic review I showed you earlier, in pediatrics, we would go ahead with MAP as the treatment of choice. However, for some logistic reasons or cost reasons, patients may not be able to get high-dose methotrexate. And so there, we personally use and advocate the Tata Memorial-based OGS-12 protocol, which is also a 3-drug protocol, but instead of high-dose methotrexate, it gives ifosfamide. Their outcomes are good. There is no head-to-head comparison with MAP. So I cannot say which one is better than the other, but we would recommend a MAP or a OGS-12 based protocol for anybody who needs, any child who needs chemotherapy for their osteosarcoma. One of the less well-known facts is whether the cumulative dose of high-dose methotrexate matters. There's not a lot of information out there. One Italian study showed that those who got 10 cycles versus those who got 5 cycles, So those who got 120 gram per meter square of methotrexate cumulative versus those who got 60 gram per meter square of cumulative had difference in their outcomes. And so it is recommended to give the prescribed cumulative dose of methotrexate if possible. Giving just 2 doses or 4 doses would not help. In the EuroAMOS protocol, the current cumulative dose is 144 gram per meter square, which is 12 cycles of 12 gram per meter square. There has been some fascination with this drug, muramyl tripeptide. It has not been used in India. It was a trial in the Children's Oncology Group in the US, which is what I showed you before when I was talking about ifosfamide, where it showed a benefit when it was combined with ifosfamide, but it showed a worsening when it was not combined with ifosfamide, and it was thought that it may potentiate the effect of ifosfamide. The jury on the use of this drug remains out, and currently, to my knowledge, the only place in the world where it's being used as part of standard of care is the UK. Other than that, it is either investigational or not being used at all. So I'm hoping that you are familiar with the EuroAMOS protocol, which has been a landmark study bringing the Europeans and the Americans together. And this talk takes high-dose methotrexate along with cisplatin doxorubicin. It had 2 randomized questions. One was to give interferon maintenance to those who had a good response on necrosis, and the other one, which was more interesting, was what to do when they have poor necrosis, and they added ifosfamide etoposide as drug number 4 and drug number 5 to those who are having a poor response. So when they added interferon, they found that there was no difference in the outcome, and there was a lot of people who dropped out of interferon for toxicity, and there was poor compliance and poor uptake of this randomization. So this is not being used now routinely. The more important thing was what to do when you give ifosfamide and etoposide added to a MAP, and this led to no difference in outcomes but caused much more toxicity. And so although we know that poor histological necrosis is associated with relatively poor outcomes, what we don't know is how to make that better. So till we know that, MAP will continue even post poor necrosis, because many children with poor necrosis will get cured with MAP. So just because you have a necrosis which is less than 90% is not a reason to abandon that treatment. Studies which have been done to abandon and switch to new drugs have shown far worse outcomes. So if you are on a cisplatin doxorubicin high-dose methotrexate arm and your patient shows poor necrosis, please do not abandon the treatment. Please carry on with the same drugs. Coming to relapse, so after the osteosarcoma relapse, the disease control is related directly to our ability to do a surgical resection. If surgical resection is not attempted or cannot be performed, then no matter what you do, progression and death are certain. So in this context, the role of chemotherapy is not well defined. Some people use chemotherapy, some people do not use chemotherapy. When given, and there are several drugs mentioned over there here in the NCCN guidelines, from etoposide to regorafenib to sorafenib to cyclophosphamide, topotecan, gemcitabine, etc. Whenever you give without getting surgical clearance, the intent would be palliative, and the benefit would be improved progression for a few weeks or a few months at the most, which in a pediatric context is not something which we get very excited about. But I know in adults, that is something which you are keen to have some improvement in progression-free survival. So that brings me to the end of the osteosarcoma. If you have any questions, any things you want to clarify, please go ahead and we can talk about it now.
So when to give IAP and when to give MAP?
It depends on your logistics. So IAP effectively is 7 months long. Sorry, IAP is 6 months long. It is 8 cycles of chemotherapy. The EuroAMOS protocol is 7 months long. It is actually 6 cycles as well, but within 6 cycles, you have to come 3 different times. So it ends up being like 18 cycles of chemotherapy. So that's the first thing to consider, that the number of times you have to come to the hospital and the duration. The second thing you have to be aware is whether you have a facility where you can give high dose methotrexate with a 2 or 3 night admission and monitor methotrexate levels. Because the IFOS docs and the cisplat IFOS can also to an extent be given on a daycare basis. So that's the second thing to be aware of. The third thing to be aware of is the cost, because the number of times you have to come adds up to the cost, particularly if you're in the private sector. The fourth thing which happens with us is that we sometimes get patients who come from outside Delhi or outside India who want to take some cycles and want to go back. And they may go back to a facility where there's no high dose methotrexate. So giving them some high dose methotrexate over here and then sending them back where they would not get it seems pointless. So keeping all these things in mind, we either offer them IAP, or if they are motivated and can access a facility and can afford it, we offer them back.
Sir, like how many neoadjuvant cycles and how many adjuvant cycles?
So it can probably be best let me just get rid of this, and I know you can still see the screen. I'm just going to take you here. Hang on, let's go to OGS 12 because it's easy to explain. So this is the OGS 12 protocol. So there are 4 neoadjuvant cycles, 1, 2, 3, 4, and then there's surgery, and then there's 4 adjuvant cycles, right? So 4 into 3, 12 weeks of neoadjuvant, and then 4 into 3, 12 weeks of adjuvant. So that's 24 weeks. If you come to EuroAMOS protocol over here, I hope you can see my arrow. So, yeah, you can see my arrow?
Yes, sir, it says.
Okay. So this is, it says here, this is 1 chemotherapy, but within 1 chemotherapy, it's 5 weeks. And it's got AP, M, and M. So there's 3 chemotherapies in a 5-week cycle. Then 3 chemotherapies in a 5-week cycle. And then 3, and then 3, and then 3, and then 3. So totally it takes you to 28, 29 weeks. So again, over here, it's 10 weeks of neoadjuvant chemotherapy or 2 blocks of therapy, and then 18 weeks after the surgery.
Okay, sir.
Okay.
Can you, sir, shortly explain like how to monitor the high dose methotrexate?
So high dose methotrexate needs, before the methotrexate, you need to make sure that the patient. Sorry, I was just somebody needs to jog the mic. Can somebody move this? Can you hear me? Okay, yeah, that's better. So you need to alkalinize. You need to make sure the KFT is fine, and then you need to give hyperhydration. Once you have achieved a urine pH of more than 7, then you commence methotrexate. You give it over 4 hours, and after 4 hours, then you continue the alkalinization and the washout. At 24 hours, you commence leucovorin. You monitor the level at 24, 48, and 72 hours, and then there's a kind of plan as to how you wash out and what you do if the levels are high.
Okay, thank you, sir.
Okay, any other questions?
No, sir.
Okay, so let's move to Ewing sarcoma, and so this is the second common bone sarcoma we see, which peaks in the childhood and age group. And again, I showed you before that the outcome has been stuck at around the mid-70s. This is a more chemosensitive tumor and a more radiation-sensitive tumor. So initially, chemotherapy used to be given for metastatic disease, but then as it was responsive, it was also felt to be given for local therapy, so the disease goes down, and that helps in facilitating limb-sparing procedures, or if it's a tumor of the rib or the chest wall or the pelvis or the vertebra, to have better surgeries or better radiation. And so most chemotherapy protocols will now give by induction or a neoadjuvant therapy followed by local control and then adjuvant therapy. So the questions which commonly come are, we use VDC-IE as a standard of care, and whether that's the right thing to use. Should we use ifosfamide, or is ifosfamide better than cyclophosphamide? More recently, in the pediatric world, there is this dose in the compressed protocol from 3 weekly to 2 weekly. There is also the difference between the American approach and the European approach, and we've got some new results on this. And then a question which is often asked is, should we do high-dose chemotherapy? And finally, what to do when there's recurrence. So the first study which decided to see the effectiveness of chemotherapy on Ewing sarcoma was randomized like this. The first randomization in one set of centers was between we will give only radiation versus we will give radiation plus VAC. And VAC over here stands for actinomycin D, not for doxorubicin, right? And then they said, okay, in the next group of centers, we will do a different randomization. We will do VAC along with prophylactic bilateral pulmonary radiotherapy. So those were the two different randomizations happening. So what happened was that as soon as they did the first randomization, they found that in the first 7 months they had recruited 3 patients, and in 2 patients they had already relapsed, and all 3 were in the no chemotherapy arm. So when they did not give any chemotherapy, just gave radiotherapy, there was in 7 months 2/3 patients were relapsing. So they quickly amended the protocol and they removed the no chemotherapy arm, which is the treatment one, and changed it to chemotherapy with adriamycin. So now the protocol looks different. The first randomization is VAC RT plus VAC adriamycin RT, and the second protocol looks at VAC RT and VAC RT plus bilateral pulmonary RT, right? And this led to these results. So the top line is the one which has doxorubicin in it. The middle line is the one which has bilateral pulmonary RT in it. And the bottom line is the one which has only VAC, neither doxorubicin nor pulmonary RT. So this established the benefit of giving doxorubicin to these group of patients in addition to vincristine, actinomycin D, and cyclophosphamide. Then the next main trial was addition of ifosfamide and etoposide. So over here, the top 2 lines are non-metastatic disease and the bottom 2 lines are metastatic disease. The standard therapy was VAC with doxorubicin, and so they gave VAC and doxorubicin, and the experimental arm was addition of ifosfamide etoposide. And so when ifos etoposide was added, there was a distinct benefit in the non-metastatic disease. But for the metastatic disease, there was no difference in outcomes. And hence, from here, VDC-I became the standard of care. So people have used cyclophosphamide and ifosfamide to see if one is better than the other. This is a slightly different backbone which uses VA-IA versus VA-CA, with V being vincristine, A being actinomycin D, C being cyclophosphamide, I being ifosfamide, and A being adriamycin. And what they found was that there was no difference between VA-IA and VA-CA. They did a second randomization and adding etoposide to the 4-drug backbone, and etoposide, which is the in high-risk arm, led to a benefit. So that is another explanation as to why etoposide is now added to this treatment. So more recently, the Euro-Ewing trial, which compared maintenance VAI, Vinc, Actino, and IFOS with VAC, Vinc, Actino, and cyclophosphamide, showed that there was no difference. This is probably the most recent advance in the outcomes of Ewing sarcoma, a randomized controlled trial done by the Children's Oncology Group for localized Ewing sarcoma, where they found that if you gave the same chemotherapy every 2 weeks with GCSF support versus every 3 weeks, you had a benefit in EFS and OS, and that was up to the tune of 8%, which was statistically significant, and the toxicities were not different. And this is what we are doing at our center now. We aim to give 2 weekly chemotherapy wherever possible. Now, you may or may not be familiar with the differences in the American and the European approach. So the COG protocols have consistently used VDC alternating with IE. The European protocols have used vincristine doxorubicin along with an alkylating agent like cyclophosphamide or ifosfamide, along with a fourth drug called etoposide. And so this is also called the wide chemo. So they gave a wide induction, and then after that they bring in maintenance therapy. So the most recent trial called the EuroEving 2000 trial, which is still not published, this is an abstract I think, is looking at two questions. Is a European backbone better than an American backbone? And is zoldronic acid as a maintenance better in improving outcomes? So we don't have the answer for the second randomization, but the first randomization has shown that after a median follow-up of 1.7 years, the VDCI strategy was a better strategy and clinically significant, and hence this randomization has now been stopped, and even in the European protocols, VDCI is being used as the standard of care. This VDCI is every 2 weeks VDCI, not every 3 weeks VDCI. The other question, which is very relevant, is the role of high-dose chemotherapy. And this is the schema of the previous EuroEving protocol, which is the EuroEving 99 protocol. I'll take you through this scheme if you are not used to this. So in the first instance, you have 6 cycles of wide, which is what I told you about recently. And then you go ahead and have surgery. Then if you are good risk disease, which is a small volume, no metastasis, etc., then you get randomized into R1, which is a Y versus VAC. But if you are a bad risk disease, like a poor necrosis, large volume, or lung metastasis, you get randomized in R2 between autologous transplant with boom-well conditioning or 7 cycles of maintenance chemotherapy. So this is the first study which has tried to randomize transplant versus chemotherapy in Ewing sarcoma to see if that led to an improvement. And it has shown mixed results. So what it has done is, I'll just go back one slide, it has divided so I'm talking about R2 only, right? So within R2, it has divided them into 2 groups. One are those who are localized but have large volume and are poor responders, so less than 90% necrosis. And the other is those who have lung mets. So when you look at the result for those who are localized, not the metastatic disease, you find that there is a difference and a benefit of doing a transplant in these patients. So in a patient with localized Ewing sarcoma who has large volume and poor necrosis, when they were given autologous transplant, they did better. However, when you look at those who have pulmonary mets, they did not do better. Both treatments were equally effective. When they have further looked at this data, particularly this part, they have concluded that the wide chemotherapy given as a neoadjuvant chemotherapy was not intense, and if we had used the VDC-IE arm, then the advantage of boom-well would have gone away. So the net conclusion of all this is that as of today, chemotherapy remains the standard of care even in metastatic disease and poor necrosis disease, and going to an autologous transplant does not offer an added advantage. There is data to suggest that adding topotecan is potentially beneficial, and the current ongoing COG trial is randomizing patients between VDC-IE versus adding topotecan and removing doxorubicin for some of the cycles. This study is still ongoing, so we do not have any data on this yet. So the choice of chemotherapy would be VDC-IE as a first-line therapy. The benefit is there in localized disease. It has not shown added benefit in metastatic disease. So it depends on what you would want to use. We don't know what is better for metastatic disease. In pediatrics, definitely a 2-weekly regimen is got us 8% advantage than a 3-weekly regimen. If the disease recurs, then the treatment depends on site and previous treatment received and patient considerations, and there's no standardized second line treatment. There are several drugs which have been tried: topotecan, cyclophosphamide, arountican, temozolomide, gemcitabine, docetaxel, and high dose ifosfamide. Myeloablative therapy has also been tried in this context, but has not shown to be superior. This is again the recommendations on second line therapy in the NCCN guidelines. And again, there is no one single preferred therapy. There is an ongoing study called the RECUR study, which is an international randomized controlled trial for chemotherapy for recurrent and primary refractory Ewing sarcoma. They have randomized patients into 4 arms, and they are giving these 4 drugs: topotecan, cyclo, arountican, temozolomide, gemcitabine, docetaxel, and high dose ifosfamide. The results just this year in the ASCO, the first interim analysis was done, and what they found was that the gemcitabine docetaxel arm was inferior to the other 3 arms. So that randomization has stopped, but the other 3 arms randomization continues, and so we don't know which of the remaining 3 would turn out to be the most effective treatment. There are other investigational therapies like monoclonal antibodies against insulin-like growth factor 1 receptor, as well as immunotherapy with CAR T cells or pembrolizumab, nivolumab, etc. But all of these remain anecdotes and case reports, and overall no sustained benefit has been seen. So that brings me to the end of Ewing sarcoma. If there are any questions, please feel free to ask them.
What is the cumulative dose of doxorubicin that needs to be given?
So doxorubicin is given in the first 5 cycles of VDC. You generally give 7 cycles. So first 5 cycles, each cycle is 75 milligram per meter square. So it's total 375 milligram per meter square.
And sir, what is the safe dose that can be given, like maximum safe dose that would be given?
Well, there is no safe dose, but we know from data that there is a jump of cardiac toxicity at a cumulative dose of around 300 milligram per meter square, and a second jump at around 450 milligram per meter square. So if you look at the the chemotherapy protocols where there's a lot of anthracyclines, like an AML protocol or a sarcoma protocol, they generally give I think a hepatoblastoma protocol, they would generally give doxorubicin somewhere between the range of 300. None of the protocols gives it about 450. So they have protocols which go up to 375, maybe up to 400. But again, if you think of patients relapsing, for example, if a patient of AML would relapse, you would then give them anthracyclines again. So there are certain situations you would expose them to more than what you would like to give. But frontline treatment, most protocols like leukemia protocol, Wilms protocol, etc., would try and limit the anthracyclines to 100 to 200 milligram meter square. For more intense therapies like sarcoma and AML, where there is a higher value with doxorubicin or anthracyclines, you would push up to 300, 350, 375 milligram meter square, but probably draw the line before up around 400 milligram meter square.
Thank you, sir. And when to use doxorubicin and when to use dactinomycin?
The current protocol doesn't use dactinomycin. So VDC-IE doesn't use dactinomycin. Dactinomycin is used now mainly in rhabdomyosarcoma or in Wilms tumor. But if you look at the previous protocols, what they used to do is, and some protocols still do, is that they would give, suppose you give only VDC or VAC, right? Now what would happen is you would give VAC for say 14 cycles or 17 cycles, but in that you would give the first 5 cycles, the A would be the adriamycin A, till you hit the cumulative dose of adriamycin, and then the subsequent A would be the actinomycin A for the rest of the treatment, like you would give in a rhabdomyosarcoma. The protocol which we use doesn't use actinomycin D, but some protocols would replace doxorubicin after first 5 cycles with actinomycin D.
And there is question by Dr. Parag, can we use lipodox and how to use doxorubicin in recurrent sarcoma of
Um, I personally, I've just saw there were some chat questions. I personally haven't used lipodox. I don't know of pediatric protocols where lipodox is used. Um, Once the um, patient relapses, then as I was showing you in the, hang on, let me just open this, in the protocol, the second line therapies over here, you would see that doxorubicin or any anthracycline is not mentioned. So it's a combination of an alkylating agent with some other drug. So the cumulative doxorubicin dose would not happen here.
Okay.
Okay. So moving on to rhabdomyosarcoma. So that this is a soft tissue sarcoma and seen predominantly in the pediatric age group. Again, showing the survival, which is stuck at around 2/3, and we haven't made progress beyond that. Uh, so all children with rhabdomyosarcoma require multi-modality treatment, which includes surgery and or radiation, as well as chemotherapy. In this case, you can do upfront surgical resection as long as it does not cause disfigurement, functional compromise, or organ dysfunction. If these are going to happen, then you should go ahead with initial biopsy. In practice, if you have localized disease, only in 14% do you do upfront surgery, and in 12% you do upfront surgery with microscopic residual disease. But in the majority of patients, you do biopsy only, which is the IRS clinical group 3. These are the patients with abdominal RMSs, patients with bladder prostate RMSs, vaginal RMSs, head and neck RMSs, parameningeal RMSs, etc. So the few places where you do upfront surgery would be like a paratesticular RMS or a very small extremity RMS, which is easily resectable. So the principles of chemotherapy over here are that all kids should get chemotherapy. How much, what drugs, and the duration are dependent on the risk group assignment. Now, there are two main strategies used, and they are slightly different, and so it can be confusing to decide which is low risk, intermediate risk, and high risk. I do not remember these. I refer to this chart every time I have a patient. So this is the children's oncology group chart, which looks at those with embryonal disease, low stage, low group as being low risk, and then there's intermediate risk, and those with alveolar disease metastatic or embryonal disease metastatic more than 10 years being the high risk group. Now this is different from the European soft tissue sarcoma group, which divides them into 4 groups: low risk, standard risk, high risk, and very high risk. And there is some overlap with the COG classification, but there are also differences in the COG classification. Again, you are using pathology, surgical stage, site, node, size, and age to determine which child falls into which group, and then give chemotherapy accordingly. So this is how the European soft tissue sarcoma group RMS 2005 schema looks like. In the very low group, you can get away with just 2 drugs, vincristine and actomycin T, for a 6-month period. In a standard risk group, you would give ifosfamide for a few cycles, or in subgroup D, you would give ifosfamide for the entire treatment. In the high risk group, there was at that time a randomized question of doxorubicin and no doxorubicin, and a second randomized question of giving maintenance treatment. And in the very high risk group, they give both doxorubicin and maintenance. So I'm just giving you the broad principles and not the specifics, because they need to take into account several things. So in the low risk group, provided that it's embryonal and IRS group 1 and a favorable site, you can give just 2 drugs, vincristine and actomycin D, for a 6-month period. If it's slightly higher than that, then you give 3 drugs, but you can cut down on some of the doses of the cyclophosphamide or ifosfamide and not give that at each cycle, but for some of the cycles. In an intermediate risk group, the 3-drug regime of vincristine, actomycin D, and cyclophosphamide or ifosfamide remains the standard of care, and this will be given depending on the protocol between 6 to 10 months. There have been studies which have shown that a certain amount of isolating dose has to be given. You cannot cut short this. I'll show you some data where the children's oncology group is now using the VAC-VI arm. So that's VAC arm alternating with V and I over here is not ifosfamide but irinotecan. And the objective is to reduce the cumulative cyclophosphamide dose. And I'll also show you some new data on maintenance therapy. So should we use cyclophosphamide or should we use ifosfamide? The IRS-4 study randomized 3 ways. VI is vincristine, ifos, and ito. VAC is with cyclo and VI is with ifos, and all the 3 were exactly the same. So in the COG American protocols, VAC remains the standard of care. They then did a subsequent study where they gave either only VAC or they alternated VAC with VI, and the outcome was similar. And so if you want to reduce the cumulative cyclophosphamide dose, then vincristine irinotecan is preferred as a combination with VAC. Now this is data from the European study where they gave 6 months of vinorelbine and cyclophosphamide. Cyclophosphamide was oral and vinorelbine was weekly IV, and they found that there was a difference in the intermediate, well, they call it high risk, but yeah, it depends on which way you define it. In the European high risk group, if you gave maintenance treatment, there was a significant difference, and now this is the recommended treatment in intermediate and high risk patients with rhabdomyosarcoma. So after they finish their primary chemotherapy, they go on to maintenance chemotherapy. In the highest risk group, which is the metastatic group, the outcomes remain poor. Overall and event-free survival of at 5 years is around 25%. A pooled analysis of the European and American groups showed that actually if you can divide this into 2 groups, so those which had more than 2 risk factors, by age, by unfavorable site, by bone or bone marrow involvement, or more than 3 metastatic sites, did far poorly compared to those who had less than equal to 1 factor. So despite this knowledge and despite trying various things, VAC remains the standard of chemotherapy. We know what the problem is, we just don't know how to make it better. And various things have been tried. Upfront window studies have been done with various drug combinations to see if that improves outcome, and that hasn't done that. High dose chemotherapy has been tried, and that hasn't led to a difference. And as I showed you before, doxorubicin randomization was done in the last EPSSG RMS 2005 study, which did not show an added benefit. So as of now, VAC or VI remains the 3-drug standard of care for intermediate risk and high risk treatment, followed by maintenance chemotherapy. For recurrent disease, what you do and how the child's prognosis is depends on several factors, and based on that, you then want to give chemotherapy to treat the patient. There are several chemotherapy regimens. There is no one universal regimen. Generally, people have used a backbone of carbo-ito, like in ICE, or a cyclophosphamide topotecan, or a vinorelbine cyclophosphamide, or an irinotecan temozolomide. Currently, the Europeans like to use vincristine, irinotecan, and temozolomide, while the Americans are using temozolomide along with cyclophosphamide and vinorelbine. Again, autologous bone marrow transplant has shown to be of no benefit. Right. So that finishes the third section, and I just got one more thing to go before we finish. So if you have any questions on rhabdomyosarcoma, you can please ask now.
Sir, the risk stratification, is it now on the basis of fusion status?
Correct. So that is quite appropriate question. So now there is no longer the use of the word embryonal or alveolar. It is now fusion positive and fusion negative rhabdomyosarcoma. We do PAX3 and PAX7 testing in our patients, and if they are positive, then they are high risk, and if they are negative, then they are on the lower risk side.
So no intermediate risk, only 2 groups?
No. So if you go to the risk, so there is the risk stratification involves 5-6 different things. The histology is only one of them, right? So what you're talking about is the pathology. So pathology previously used to be embryonal as favorable and alveolar as unfavorable. Now it is fusion positive as unfavorable and fusion negative as favorable. It still has to take into account all the other things: the site, the node, the metastasis, the age, the size, the IRS group. So once you do all that, the risk groups are still 3 or 4 depending on whichever protocol you use. The refinement is only in the pathology.
Okay, sir.
Okay, any other question? So we'll last move to the non-rhabdo soft tissue sarcoma protocol. Now this is not one disease but an umbrella of diseases, and again some of these are specific to pediatric groups and many of them are what you would see in adults also, and of course many of the adult ones we don't see in children. So there have been two main standard of care studies rather than randomized studies. One is the Children's Oncology Group, ARST 0332, which gave risk-based treatment for non-rhabdo soft tissue sarcomas. And there is a huge list of these cancers. Obviously, I'm not going to go through these lists, but this is from their protocol where they identified these cancers as being called non-rhabdomyosarcoma soft tissue cancers. So their schema was like this, that if it is a non-metastatic disease and a low-grade disease and is resected completely, then it is low risk and you can observe, right? Same would be over here if it is a metastatic disease but a low-grade disease and all the local and metastatic disease has been resected, then you can observe. The other arm is when it's a non-metastatic disease, it's a high-grade disease, but it is less than 5 centimeter and the margins are positive, then you would add radiation to it. So those are the two indications where you would only do surgery or do surgery and radiation. For everything else, you would do chemotherapy. So if it is more than 5 centimeter and high grade, if it is unresectable, if it is metastatic, you would add chemotherapy. And depending on, you may do neoadjuvant chemotherapy or straight away adjuvant chemotherapy. So the treatment which they are using or the chemotherapy which they are using is ifosfamide doxorubicin. And there are slight variations with regards to the, whether you use 6 cycles or 5 cycles or whatever, but they are, or you're using it as adjuvant and neoadjuvant, but essentially you have total of 6 cycles of ifosfamide and 5 cycles of doxorubicin in the Children's Oncology Group arm. And with that study, they were able to show that in the low risk group, you have a 96% 5-year overall survival and almost a 90% 5-year EFS. In the intermediate, it's close to 80% overall survival, and a high risk group, it's close to 35% overall survival. The second major study group is the European group. They also have a similar standard of care protocol. They also have done something similar. Synovial sarcoma is one group, adult type soft tissue sarcomas are the other group, and then they have a number of other histotypes for which there are some specific recommendations. And again, their treatment is broadly similar. So if you are upfront surgery done less than 5 centimeter, it's surgery only. If it is less than upfront surgery is got positive margins, then you add radiation. And of course, it's more than 5 centimeter, then you, or it is nodal disease, you would give ifosfamide and doxorubicin. The doses are slightly different. Same with adult type soft tissue sarcoma. Again, I'm not going to the specifics, but you should understand the broad principles, where if it's low grade and small size, surgery only. If it's low grade or intermediate grade, but more than 5 centimeter, resection is good, then you can add radiation. But anything other than that, please add chemotherapy as well. And the chemotherapy agent remains ifos-dox. A number of these drugs have been explored in adult soft tissue sarcomas, but they haven't been explored in pediatrics, so they are not employed in frontline care. There are a few specific tumors I wanted to talk about. One of them is desmoid type fibromatosis, which we tend to see a fair amount of, and that's because it doesn't kill the people, but it keeps coming back. And so patients often shop around going to different hospitals, and they have multiple interventions done. So in the past, people would attempt surgery and then offer radiation if the margins are positive. Increasingly, the surgery is becoming uncommon. Upfront drug therapy or chemotherapy is becoming the standard of care. The goal is not to go into CR or PR. If you are able to achieve stable disease, that is also an acceptable goal. So several chemotherapy agents have been tried, methotrexate, vinblastine being the most popular, and then some other oral drugs like NSAIDs and tamoxifen have been tried. There is more excitement recently about the 2 randomized controlled trials, which in fact are the only 2 randomized controlled trials in this disease group, which have been done in adults though, not in children, where they have used either sorafenib against placebo or pazopanib against vinblastine methotrexate, and showed that at 6 months and 12 months, the outcomes are far more superior. For dermatofibrosarcoma protuberans, which cannot be resected, it has a translocation which is associated with the PDGFR-B gene, which makes it amenable to imatinib therapy. Inflammatory myofibroblast tumor, wherever possible, surgery remains the treatment of choice. But if surgery is not possible because of the location, or it is progressing because of partial resection, then you can offer steroid therapy, chemotherapy, and in 50% of the cases, they will, because they express ALK, you can use ALK inhibitors. Something which is very unique to pediatrics is a congenital infantile fibrosarcoma, can be diagnosed at birth or shortly after that. And these tumors are often in the limb, have an excellent prognosis. Complete resection is curative in most patients, but because of a large tumor, it often would mean amputation in an infant, which would be unacceptable to most, and hence chemotherapy is given. They're also very chemosensitive, and with chemotherapy they can cause you can have a more conservative surgery, and because they are exceptionally chemosensitive and they are very young children, you can get away without giving alkylating agents and without giving anthracyclines, and leaving them for salvage therapy. So something like vincristine actinomycin D alone may be adequate. And this is highlighting the excellent outcomes which these cancers have. There are some patients in which surgery alone, like the group 1 and group 2, is adequate. And chemotherapy is left for those on whom a salvage needs to be done. But this is a very small number. Most patients are in group 3, so they need chemotherapy and then a more conservative surgery. A desmoplastic small round cell tumor affects children and young adults, predominantly in the abdomen with widespread abdominal involvement. It is a bad disease. Overall prognosis is extremely poor. There's no standard approach. VDCI, like in Ewing sarcoma, is the preferred approach, but the only way to cure is complete resection after surgery to be clear of every disease which is visualized on surgery. Some people have tried HIPEC in these patients, but that is investigational because the results have been mixed. Coming to rhabdoid tumors, these are tumors which we see in the very young. In the brain, they are called rhabdoid tumors of the brain, or atypical teratoid rhabdoid tumors. And they can also happen in the kidney, they can happen in soft tissue, they can happen in the liver, they can be an inherited gene as well. So they are very aggressive. Chemotherapy is used. There's no single regimen, but the chemotherapies are more aggressive than the standard soft tissue sarcoma treatment with carboplatin, doxorubicin, etoposide, etc. But despite all of this, outcomes remain poor. So that brings me to the end of this. I'm happy to take any questions about an RSTS or anything else overall. So thank you for your time.
Thank you so much, sir. It was indeed a wonderful lecture. If there are any questions, please unmute and ask.
Okay, I think there are no more questions then.
Sure, sir. So
Thank you so much.
we are really thankful to you, sir, for spending your precious time, sir, and wish you a happy Teachers' Day, sir. Thank you so much.
Thank you. Thank you. Thank you, Naveen.